The purpose of this video is to give detailed instructions to the surgeon about the operative technique for the HipSextant navigation system. After confirming that the plan is showing the correct patient and the correct side, the next thing that you should notice is the default cup orientation set up for the patient. This is based on the preoperative supine pelvic tilt and on our current knowledge of the acetabular orientation safe zone. The definition of pelvic tilt is depicted if the question mark next to that parameter is selected. Lumbosacral lordosis is associated with positive pelvic tilt, whereas lumbosacral kyphosis is associated with negative pelvic tilt. There are several mathematical definitions of anteversion and inclination for acetabular cup orientation. We have chosen to use the operative anteversion and operative inclination angles defined by David Murray. You can see graphically exactly how these angles are defined by clicking on the question mark next to the angles. You should know that a cup that is in 27 degrees of operative anteversion and 40 degrees of operative inclination, for example, translates to about 20.4 degrees of radiographic anteversion and 43.3 degrees of radiographic inclination. This means that aiming for 39 or 40 degrees of operative inclination will result in cups that appear to be between 42 and 45 degrees of inclination on postoperative radiographs. The surgeon is free to change the desired cup orientation goal as he or she wishes, either preoperatively or intraoperatively, by using the sliders or the up and down arrows. You should also know that the default plan deliberately does not incorporate measurement of femoral anteversion. This is primarily because the anteversion of the femoral broach achieved in surgery may not match the native femoral anteversion. This means that the femoral anteversion should be determined by the surgeon intraoperatively. If significant residual anteversion deformity is accepted on the femoral side, the cup orientation goal can be altered by the surgeon accordingly. Once the desired cup orientation is determined by the surgeon, you will see the necessary adjustments for the HipSextant instrument in the lower left-hand corner of the viewer screen. The pin distance is the distance in millimeters that the two arms should be set to. In this case, the pin distance is 116.5 millimeters. Please note that the hash marks on the arms are 2 millimeters apart. The in-plane angle in this case is 38 degrees. The adjustment on the instrument is shown here. Please note that the hash marks are every 2 degrees. The off-plane angle in this case is 24 degrees. The adjustment on the instrument is shown here. Again, please note that the hash marks are every 2 degrees. Once the acetabulum is reamed and the cup is ready for implantation, the base point pin should be inserted. Understanding the process of placing the base point pin is the most critical aspect of using the HipSextant. In order to find the correct location for the base point pin, a calibrated drill guide is used. You will find that it is easiest to insert this by temporarily replacing your posterior retractor with your non-dominant hand and then feeling the posterior rim of the socket. The finger of the calibrated drill guide is then placed into the infracotyloid notch. Take care not to place it in the region of the transverse acetabular ligament. The tip of the drill guide itself is then brought up and over the posterior rim of the socket to sit on the posterior wall. Care should be taken to ensure that no soft tissue is interposed between the drill guide and the bone. The next step is to roughly determine the correct angle of the drill guide. Since the exact position of the pelvis in space is not known at this point, the drill guide angles that we show must be understood in that context. You should also understand that you are trying to identify a point here, not a line, so the exact angle of the pin does not affect the accuracy of the system very much. You will notice that there are two drill guide angles shown in the plan. One is the drill guide angle in the coronal plane, and one is the drill guide angle in the transaxial plane. The explanation of these angles is graphically depicted if the question mark next to the angle is selected. This image shows the definition of the coronal drill guide angle. you will notice that positive angles aim from proximal to distal. This image shows the definition of the transaxial drill guide angle. You will notice that positive angles aim from posterior to anterior. You will see on this pelvis model that varying the coronal drill guide angle changes the location of the base point pin quite a bit, whereas varying the transaxial drill guide angle does not affect the location of the base point pin very much at all. This means that you should focus especially on the coronal drill guide angle primarily. Align the drill guide and insert the base point pin about 10 millimeters. Then remove the drill guide. Check the inside of the acetabulum to make sure that the pin did not penetrate. Now place the acetabular component into the prepared acetabulum and then slide the HipSextant over the base point pin to dock the base point cannula onto the bone. Again, please be sure that no soft tissue is interposed. Clamp the cannula onto the pin using the 7 millimeter wrench on the collet nut. Once the base point leg is docked, feel the anterior superior iliac spine and align the anterior cannula to aim directly at the lateral edge of the ASIS. Insert the sharp trocar percutaneously, either by making a tiny incision or by accelerating the pin rapidly. Lock the trocar into the cannula and move the tip of the trocar to probe the edge of the ASIS. If you have trouble identifying this location, you can remove the trocar from the cannula and use it as a freehand probe instead. Once you are sure that you are docked on the bone just back from the edge of the ASIS, hold this position. The second trocar is then inserted through the apical cannula and locked into position. The instrument finds this location automatically. In navigation terms, the pelvis is now registered and is being tracked by the instrument. Place the direction indicator onto its supporting pin and begin to align and insert the cup. Placing the cup handle parallel to the direction indicator controls both anteversion and inclination. It is best to remove the direction indicator when you are using the mallet so that it doesn't vibrate too much. Once the cup is approaching the final orientation, you can use the parallel guide instead of the direction indicator to be certain that your cup orientation is as accurate as possible. Once the cup is implanted, check to see that it is fully seated before removing the HipSextant. Then loosen the base point collet using the 7 millimeter wrench. Remove the base point pin and then remove the instrument. When you first begin to use the instrument, you will sometimes find that the direction indicator is pointing in a direction that you would not have anticipated. If it is docked correctly, this means that the pelvis is significantly malpositioned on the operating table. If you feel insecure about the orientation, just double-check that the instrument is docked correctly. It can be helpful, especially in complex cases, to do a trial reduction before removing the instrument. If you detect unacceptable instability or impingement in a certain direction, the cup orientation goal can be changed a few degrees and the instrument can be readjusted while still in place. Eventually you will find after several cases that you will be able to use the device within about 3 minutes of OR time.